Hi, everybody. Welcome to Café on Tampa Online. My apologies that we're running late. My internet went out, which was my fault. And I'm trying to run this off my phone. So if you have problems getting access to it, post underneath and we'll see that. Don't forget you can ask questions by posting underneath as well. I'm going to hand off to Del.
Wait a minute, Bill. I just lost. Hold on, Bill.
Jason, can you hear me?
Oh, I hear you fine. Yeah.
Okay. I'm
Dr. Jason Wilson is ER doctor with TGH and has spoken at Café on Tampa multiple times. Jason, you spoke to us online. You were one of our first online interviews, and you were warning us about the different curves that were going on. Can you just give us a quick update on what you see is happening right now from your point of view?
Yeah, Bill, I sure will. And hopefully if you're inside a space with other people there and you're not able to social distance, you're wearing your mask. And I'm sure we'll talk more about masks as the conversation unfolds a little bit. That's some really important development, public health intervention developments in the past couple of days as well. But let's go to an overall picture of where we are now compared to where we might have been back when we talked probably early April, I think, is when we last spoke. And unfortunately, I'm not bringing you any good news. I would say, overall, the picture is in some ways for the virus itself, we're in worse shape. The only positive there that I can spin that with is that the community itself is probably in better shape. So what do I mean by that? So what I mean is that we've kind of, since March 13th, have been watching at first a steady rise of cases take place, then sort of a constant rate of cases take place, never really reached a plateau. We actually were always rising just a little bit, even in late April and throughout May. The difference was that throughout March, we were seeing what we call exponential rise, meaning the amount of rise each day was increasing as well as the number of cases were increasing each day. Now, as we kind of moved into April into May, fortunately, all the things we were doing in Tampa and throughout this area, they seem to really be working. We did a lot of social distancing, a lot of safer at home type of interventions. And what we saw happen was that the curve itself bent. So the rise and the number of cases per day really came off like this and bent over. And like I said, we never really flattened. We never got like this, and we never saw what we really want to see is a hump. We want to see that curve go down. So if you go and look at places like Italy, Denmark, Austria, Germany, they have a curve that goes like this. So they've ridden down the slope. So for us, the best we did with social distancing and safer at home policies, we did a great job of bending the curve. We decreased the slope. We decreased how big that roller coaster ride up was by making it more constant. And we kind of rode like this for a while. That was an okay place to be. It wasn't great, but it was okay. And we were able to deal with that, I think, from a healthcare system perspective. That is the classic flatten the curve argument. Like I said, not quite flat, but at least slow down a little bit so we had some time. That allowed the healthcare systems to really respond to the virus and to think about ways to treat patients safely. And that's an important point to talk a little bit about. That's the part I mentioned earlier. While the virus may be in worse shape, the community's in better shape. So because of that really good job of the citizens out there of slowing the curve or somewhat flattening the curve, we were able to put together a really robust public health infrastructure. And so that infrastructure, has hospitals sharing data, it has available bed space, it allows us to think about the right way to treat patients. All those things are good. And then as we roll into May, what we see is hospitals begin to reopen for elective surgeries. We think about ways to treat patients who are coming for a COVID complaint or for non-COVID complaint safely. We cohort those patients at all the hospitals in the area, and we're able to kind of maintain that flow. So we had a lot of practice. We had a lot of practice getting better and thinking about how to do this the right way. So now the problem that's arisen is as we roll into June, 2 or 3 weeks after phase 1 reopening, a couple of weeks after phase 2 reopening, about a week after holidays, social demonstrations, other things like that, more and more people close together, more and more people not doing safe at home any longer, people not wearing face masks or face coverings either, now we start to see not just a little rise in cases, but really an exponential growth in cases. And so I think what most people have heard by now is essentially day after day, we are breaking our day before record for the number of new cases presenting to us in this area.
Jason, what you talked about flattening the curve in the beginning, and everybody did a good job of that. And it seemed to me that at the time that the state opened back up, we were kind of where we were on the curve when we closed everything. And it seems to me that we should have waited a couple more weeks or another month. Now that's in hindsight, but what else could we do now? And I don't know if we talked about your credentials at the beginning. So there's a lot of partisanship on all of this, but can you just tell us real fast what your credentials are, and also clinically how you look at these things, and then what would be your recommendation for all of us to try to avoid getting it now?
Sure. So for those of you who didn't join us on our first time, we talked about this back in April. I'm an emergency medicine physician. So I see patients with COVID every day. I treat patients with COVID, diagnose patients with COVID. I've been involved heavily in kind of designing the strategy for our hospital to how we want to manage, treat, screen patients, move them through the hospital, move other patients to the hospital safely at our institution, and involved also sort of throughout healthcare systems and throughout the county, kind of thinking about what the right thing to do for these patients is. So I've been involved pretty heavily in the operational and clinical management side of COVID since the beginning. And I think, Billy, you bring up a good point. We went to safer at home kind of late March moving into April, and where we were on that curve was probably that same acceleration point as to when we went to phase 1 reopening. Now, look, there's a lot of pressures and competitive interest as to why you may need to reopen the state, and I understand those, right? So a hospital needs to do procedures for people who need procedures, and a hospital needs to take care of sick patients, people who need surgeries. During the safer at home part of this pandemic, we actually saw a decline in emergency department volumes of over 50%. And that's not just low acuity patients either. Our high acuity patients disappeared as well. And so heart attacks, strokes, other significant infections, we didn't see as many of those patients. And that's not because those patients weren't having events. I think those patients were worried about coming to the hospital. And the CDC releases a weekly report. Some of the last 2 weeks of the reports have really shown that other types of deaths have also risen during that period of time. So I get, for some economic reasons, some other patient safety reasons, why we have to, try to relax some of those social distancing measures. Now, having said that, if you're going to take one public health policy and move into another public health policy, you have to understand what the risks, the benefits, and the harm of that are. So overall, the way I think about social distancing, or let's be specific, the way I think about safer at home is that's one specific public health intervention that allows us to decrease viral transmission. Now, that's just a tool in the toolkit. There's a lot of different possible tools in that toolkit. Another one, for example, is hand washing. Hand washing is a very effective and important tool to decrease viral transmission. On its own, it's actually almost as effective as safer at home orders. Now you put those two things together, right, and you start to really decrease viral transmission. There's this number that I think most people may have heard of by now if they're watching this type of a show. It's called the R naught, and that R naught is the reproductive rate of the virus. How many people get the virus if you have the virus? How many people you're going to give it to? And so a really significant infectious process like the measles or Ebola, these have R naughts that are greater than 3, maybe approaching 4 or 5. Less virulent infectious pathology, say like the flu, the common flu, probably has an R naught closer to 1.3. So where does this live? It lives somewhere in that 2.5 range. That means for every person, so if I get COVID, I might give it to 2 to 3 other people. Now, the whole point of all these interventions is to decrease that number, because when that number gets less than 1, we stop increasing cases. That's the goal. The goal is to get that number less than 1. There's a lot of ways we can get there. for a while, we needed to do safer at home because we don't want to overrun our healthcare systems, and that's an effective strategy. So we did safer at home, and we met the goal of not overrunning healthcare systems, and we did decrease the R naught. Now, now the healthcare systems aren't overrun, and that people need to go to work and to generate revenue, and all these other things need to happen. How else can we maintain a decrease in R naught? So that's the questions on the table now. So if we're going to be back out there some, what do we have to do instead? So again, hand washing, very effective. Not touching your face, very effective. Dell is showing us an example of another effective technique, and that's face coverings or masks.
Dell, say something so we can see you.
Well, Jason, I want to ask you a question.
Sure.
Is because you're talking about what I'm hearing. Let me take it off. I'm alone over here. It seems like it's possible to open up the economy and still reduce transmission by following the guidelines that you've very well articulated. Why aren't, and I know this is a hard question to answer, why aren't people following them? Today I went to CVS, and there was 2 people in the store, and maybe there were 10 customers in total. 2 of them didn't have masks. Publix, I went there last night. People are there without masks. So these very basic things are not being adhered to. What do you recommend so that we do have, mandatory face masks, hand washing, social distancing? The other thing is it's hard to keep people away from you.
Yeah, it's a great question, Del. So let me start somewhere and I'll move into it. So one thing to understand is, remember that curve for a second. We never really flattened the curve or bent the curve. We've been riding a wave that's been cresting for months now. So overall, things have been getting worse in terms of viral transmission for months now. We held it off for a while by doing safer at home. There's some repercussions to safer at home that we've been trying to get out of. I want to remind people the reason why we're doing all this, even though the case fatality rate of the virus itself, when we don't have a lot of cases in the community, is low, not as low as the flu, it's about 10 times the flu, but it's still fairly low. If we get to a place where we overrun the healthcare systems, then we will see a rapid increase in the case fatality rate. That's why we're doing all of this. We never got out of that first wave. We're still riding this wave and it's still increasing. So that's important to understand. So now we're taking one public health intervention off the table. That public health intervention was safer at home. Okay, that's a policy decision for a lot of reasons, a lot of interest there, and some are very rational, well-minded interests in terms of getting people revenue they need to feed their families and survive, and getting sick patients to the hospital. So if we're not going to do that, then we have to have a trade-off. And that trade-off is we're going to have some personal responsibility about mitigation strategies. Because right now, the ways we decrease that R naught, the ways we decrease that transmission rate of the virus, they're up to us to do. And those are the things like you're mentioning, Del: hand washing, face masks, not touching your face, staying 6 feet apart, no groups more than 10 people. Now, I do want to talk about, I think one thing that's important is we've had a lot of movement around face masks in the past few days. The public got a very confusing story around face masks, I think, early in this virus, which hurt the cause. But where we are now, I think, is a better place. Let me say what I mean by that. Overall, if the amount of virus that's out there is not very much, then we probably don't need to worry about face masks. So in February, you heard a lot of your public health leaders say, look, I don't think face masks are the thing you need to worry about right now. Just wash your hands, do some basic measures, and we don't need to worry too much about this. Now, and there also wasn't very much data for face masks if you go back to February. So one of the things that changes, though, when you have a global pandemic that touches the lives of billions of people, is that you have the ability to rapidly accumulate data. And so what we have now are case studies of real data coming from China, from Italy, from Denmark, from Austria, from all these places that have gone through this and have bent their curves. We have real data about what worked and what didn't work. So I want to make sure everybody understands that there is crystal clear data now, that there is a benefit of wearing face masks and face coverings in indoor places where you're going to be around somebody less than 6 feet, or in situations where you can't socially distance around people less than 6 feet. So there is now data that shows that if I wear a face mask and you're not wearing a face mask, I at least protect you a little bit, because some of those particles that I might cough sneeze, or even come out when I talk will be stopped by my face covering. Not all of them. Some particles will still go through a cloth mask. This is a pushback I've seen kind of out there in social media. But if we both wear face coverings, I wear face covering, you wear face covering, now the probability of a particle going through both those face coverings is extremely low, extremely low. So we've made a decision, which is what we do in democracies. We make decisions about which intervention do we want to pick. And we've picked no safer at home intervention right now. We think that the benefits of not being safer at home outweigh the risk of safer at home outweigh the benefits, and that's fine. But if we're going to pick that, then we have to do things that we know work, like face masks, washing your hands, staying away from groups, and staying more than 6 feet apart. Another piece of that too, I'll say before I go into face masks, kind of some of the changes we've seen the last week are contact tracing. So if we want, there's always a balance of public health.
Jason, explain what contact tracing is for our audience.
Sure, that's great. So contact tracing is this concept in public health that if I can identify a person who has virus, so once I tell you, hey, you've got COVID, now I try to figure out a couple of different things. I try to figure out, where did you get COVID from? Can I figure out who in your circle of people may have had COVID, and who have you put at risk for giving COVID to? Who have you been around that might be at risk for getting COVID? And so I want to try to build a network out of all those places where you might have gotten COVID from, all those places where you were at with COVID, and all those people you've encountered that you have now potentially exposed to COVID. Now, in the old public health model, that's a manual process. What we have learned both from our own experiences and from other countries that have gone through this is that in the year 2020, it's both a difficult manual process we probably don't have the bandwidth for in terms of human resources, but it's also one where we could probably do better by using technology, right? It's 2020, we all carry one of these around. Why are we doing so much manual contact tracing when my phone tells me if I'm at a certain store, it pops up with the store's logo? That's kind of the idea of contact tracing. Now, the debate around contact tracing is that to do contact tracing right, we probably have to be willing to exchange some privacy. And again, this goes back to that idea of a social contract and a democracy of what do you want, right? So we're always making concessions about the thing we want the most. So I don't want to be stuck at home either. So if we don't want to be stuck at home, we're going to have to do these other things. We're going to be very aggressive about these other things: face masks, washing your hands, social distancing, and I would say contact tracing is part of that. And that's probably the part that we haven't really gotten to yet. That's probably the 2.0 version. We're just now at like face masks, right? That's this week. So at some point, if the virus keeps on getting worse, if you look at other countries and other places that have done a better job than we've done of decreasing, mitigating viral spread, of decreasing transmission, that next piece that's out there is some type of aggressive automated contact tracing.
Hey,
Now,
Jason, let me remind everybody, we do this because we want to bring information to people. So please hit the share button, whether you're watching it live or later, because please share it with your friends. And if you have any questions, post underneath. We've got a whole bunch of questions I want to get to. You were about to get to masks. What is your recommend? There's a whole conversation going on that I'll have to fill you in. I don't know if you can see it, but let's just stick with the mask first. What do you think is the best kind of mask? And somebody posted about OSHA and how some masks might be actually dangerous for certain kinds of job situations. So
sure, those are great questions. And so, okay, a couple of things about what type of mask to wear. It's somewhat situational dependent. It depends on who you are. Now, when I go to the grocery store or to CVS or whatever, the gas station, I wear a cloth mask like most of you are probably wearing. Mine's a little fancier because we've got some OR people who made nice fancy cloth masks for us, but it's a cloth mask. If I was going to grade it, I'd grade the same as any other cloth mask that you've made yourself or bought off the internet. That's all I'm wearing when I'm not at work and when I'm going to the grocery store. Now, if I walk into a hospital setting, right, that's a different story. If I'm in front of a patient who I just diagnosed with COVID, is very sick in front of me, then I'm going to wear kind of the other extreme of this, which is an N95 mask. An N95 mask means that 95% of all the things out there are filtered out when I breathe in. These masks, just so you know, are really made to protect what I breathe out. So it provides some protection. Obviously, there's a big micron hitting it. It's going to provide some protection of inhalation. But the idea is I'm protecting you. I'm protecting you in case I have COVID when I won't spread it to you. So in a hospital situation, I'm around a patient who has COVID, I'm wearing a mask that protects me from breathing in the COVID. That's an N95 mask. We probably don't need N95 masks in the general public at this point. Cloth masks, given where we are, what we're trying to do is a broad-based public health intervention to decrease transmission from you to somebody else for the most part. So for the most part, in a public health setting, a cloth mask is completely adequate. Now, if you've bought some masks or you've accessed some medical grade masks, we can grade those masks. There's sort of 2 grades of medical masks under N95. That's a procedure 1, a surgical mask level 1, and a surgical mask procedure mask level 3. And you'll say on the box, most people are probably buying, if they're buying disposable masks, a level 1 mask. A level 1 mask is fine. To give you an idea, when I wear a level 1 mask, I wear a level 1, and these are like the yellow little masks that have like the ear loops. They might be blue and have little ear loops, but they don't have, I don't have one with me, unfortunately, but a 3 would have these kind of like, this is not a level 3, I'm just showing you an example, but it'd have these like ridges in it. It'd have all these folds to increase surface area protection. A level 1 won't have that. It'll just be a sort of a papery kind of thing you loop over your ears. And that's fine. That's what I would wear if I came out of a patient room and I was sitting at my computer and I was typing some notes. I'd wear a level 1 mask. If I was going to see a patient I didn't know had COVID, I'd wear a 3, a procedural mask, which has those ridges. So that's kind of a in the weeds version.
Let me ask you another question real fast. So a friend of mine who's in the medical device industry, we've got a huge medical device industry in this area. So I'll tell you what he wrote, and I won't pronounce it correctly, but here's what he says. Microbiology doesn't behave like ocean waves. Viri reproduce asexually and as such are highly prone to degenerative mutation, Mueller's ratchet, which means that viri tend to degrade, and contrary to Hollywood science fiction movies, they become less virulent. So
sure, that is true. So what I would say is obviously not all the particles that are become less virulent. It is one of the reasons we may not have seen so much spread from the protests, for example. Just if people are curious, I don't think I've seen one definitive documented case from a demonstration so far. What we're seeing it from is mostly indoor spaces of people in very close contact. There are graphs out there you can Google around and find. New England Journal's done a lot of these in the last few months that basically will take a particle, dye it with some kind of colored dye and sort of see how far that particle can go, and then kind of throw the coronavirus decay curve on it and try to figure out, okay, virus is going this far, this period of time, this much is going to degrade, how much is going to be left. So there's going to be some out there, there's going to be some that's not out there, but the bottom line is there will be virulent particles that are out there that are contagious, and we're just trying to do our best to cut those down. Because obviously, whatever the theory you might have or hypothesis you might have about virulence or transmission, the reality of the situation is we have known community spread going on. And that community spread is taking place by groups of people talking and being around each other. That is what is happening.
So now in the beginning, very few of us knew anybody who had it. Now everybody knows somebody who has it. I just got a text from another person I know that has it. So people are worried that they might have, or they might have been exposed to it. I went to TGH the other day and had a great experience. But TGH is not set up to handle everybody, I think. Where should people go? I think there's a hotline maybe. Tell us what people should do to set up a test, and how do they go about it?
Yeah, great question. So a couple things. One of the, if you're not feeling sick, does it change anything to know if you have coronavirus? First of all, let's just start there for a moment, okay? If you're feeling sick, like I think I may be in the hospital kind of sick, come to Tampa General. That's what we're here for. We're a safe place. We certainly want to see you in Tampa General. If you're not feeling sick, if you're worried about exposure, or if you're just concerned about maybe needing to travel, it probably doesn't help too much to come to Tampa General right now. And whether it helps you even to know you have virus or not, it's another question. If you can isolate, just like you would for any other virus, actually, we just talk about that. It's an important point. As we got better at dealing with coronavirus, the influenza rates this year plummeted. got destroyed. So influenza B was like, started out going crazy this year. We were seeing a ton of influenza B. We got better at doing social distancing and it just fell out of the floor. So what we've learned is that there's a lot of things we should be doing for viruses that we didn't normally do that we should do, period. So if you can't get tested, it may not be an emergency that you can't get tested. You may just need to isolate yourself until you feel better. Having said that, I understand there's a lot of concern and a lot of public health desire and a lot of just personal anxiety around this and not wanting to expose colleagues and friends and family members. And so there's a desire to be tested. Ideally, there are a number of sites throughout the city and county where you can be tested. I know that there is a bit of a backlog right now. I can tell you, being on some of the calls in the past couple of days, they're working hard to kind of get back up to speed. But the county does offer free testing. I don't have it in front of me, but if you Google it or you go on the county website, there'll be a phone number you can call and it'll direct you to different places. There is free county testing available. CVS also does testing. They're doing testing, I think 3 days out. You can schedule an appointment. The Tampa General Fast Track Urgent Cares are doing testing. There is a bit of some limitations in that right now because of the surge in the demand. One thing to keep in mind too is that if you were just exposed to COVID, it probably doesn't make sense to come get tested yet. It's going to take 5 to 7 days to really increase the sensitivity of the test. So if you're asymptomatic and you're exposed today, right now, coming to Tampa General or going to seek testing tonight is probably not going to be very beneficial right now. Our advice to you would still basically be to isolate yourself for 14 days because we'd be worried about the possibility of nothing who had just been exposed.
Jason, you've been very clear on the importance of wearing a mask, social distancing, washing your hands. Yesterday, I don't know exactly what the name is, but the county board that's responsible for this barely passed the requirement of wearing masks. What are we missing here? That why are we all on board this? It's so important.
And it's such a, when we think about public health interventions too, we think about costs and harm, and there's essentially, there's free masks out there. I'll tell you about those in a second. And there's really no harm. So, I don't know. But let me talk about the sort of ongoing policy around this a little bit. A lot of places that have seen COVID at the prevalence we have in the community have passed mask ordinances requiring the use of masks in places where people can't social distance or are going to be inside. As a matter of fact, my friends, even non-medical friends and people I know in Illinois and California and Massachusetts and Maine are shocked that we don't have a mask ordinance here or statewide. Well, there was some movement there, Del. Last Thursday, it's called the Emergency Policy Group. This is, 5 days ago. The Emergency Policy Group met at the same time as the Healthcare Advisory Board. These are both county-wide groups. The Emergency Policy group is made up of, it's a group of 8 people who make all the emergency decisions around COVID. They issued the emergency plan for COVID in this area. So that group of 8 people, and Member Snively from the school board, those 8 people are very important for directing public health policy and sort of the mechanism to enforce that policy throughout our entire county. Now, they met last Thursday, and for the first time, based on really, Overman and Merman and Mayor Castor sort of leadership and Chairman Miller's leadership, they kind of moved to at least hear the idea of wearing masks this week. And so last Thursday, they voted 5-3 to listen, to entertain the concept that maybe masks are useful. And this was somewhat of a pleasant surprise because a couple weeks previous to that, they had struck down an ordinance to require masks within businesses. And so this was a progression from that. Now, after that meeting, the Healthcare Advisory Board that I sit on for the county, we also passed a unanimous motion to recommend to the county, that's our job, is make recommendations to the county, to recommend to the Board of County Commissioners that we should have a mask ordinance. So those 2 pieces of information were out there. And then on Friday, or right after that meeting, actually, the mayor of Tampa issued a ordinance for Tampa that said, starting Friday at 5 o'clock, this last Friday at 5 o'clock, that mask wearing within indoor spaces and where you can't socially distance more than 6 feet would be mandatory. So that was our first in this area, our first mask ordinance. And it happened at the same time as Rick Kreisman's ordinance passed over in St. Pete.
Jason, let me ask you another question before we get cut off. We're running a little bit long. If you have to cut off, let me know. But one quick question. I think the governor got a little bit in trouble today for saying this, but there are some benefits in getting it now versus 3 months ago, right? 3 months ago, the medical professionals didn't exactly understand the treatment that should be used. I think some people early on were given the wrong kind of Advil or whatever, and now it seems like the death rate is lower. The number of people on respirators seems to be lower. Am I correct in any of that? And why is it? What has the medical profession learned? And is it better to get it now than it would have been a few months ago?
Yeah, so a couple of things to that. So I think one thing that's important to note is that we had a lot of lead time for this, what I call surge that we're now seeing. We had a lot of practice, and that's good because healthcare teams learn to work together. All the hospitals, whether it's Tampa General, Advent, HCA, Baycare hospitals, all kind of learn how they want to manage COVID patients. So from a system standpoint, absolutely true that we are much better at doing this than we were 3 months ago. The hospitals are safe. Even if you came in with a stub toe, you're not going to look. I feel safer when I'm in at work, when I'm at the hospital, than I do at any other place in Tampa. I mean, we are totally safe in terms of catching COVID from patients or from each other. I feel very comfortable from that standpoint, and patients should feel very comfortable coming to the hospital for other things. Now, the thing that I want to remind people of is there is no FDA-approved treatment still for COVID. Okay, there is no FDA-approved treatment. Do we have better options? Probably. We've seen a couple things respond well in trials. We've seen signals for good medications. There's an antiviral medication we've heard about in the news called remdesivir. The FDA issued an emergency use authorization for remdesivir, and we do use that. Keep in mind, an emergency use authorization means we don't really have much data for this. We're in the middle of an emergency. We haven't really seen any harm. There might be a benefit. Go ahead. Okay, that's an emergency use. As a matter of fact, they just recalled an emergency use authorization they issued early in this pandemic on hydroxychloroquine, which you've heard about in the news. That was revoked because of no data support. So being in a place where we have emergency use authorizations is not a great place to be. We'd like to have an FDA-approved product to use, but we do have remdesivir. We also have convalescent plasma, which is people who get sick with COVID. We follow them. Later on, we get their blood from them. Most people who've had COVID and do well really want to help out. When they mount antibody to COVID later, we can take that blood and give it to sick patients in the hospital. So we have both convalescent plasma, remdesivir. We work really well as a healthcare team. We kind of understand the disease a little bit more, but there's still no FDA-approved treatment. Now, to your other question about ICUs and deaths, a couple of things around that. We actually had some really good success stories in this community around COVID. That's good. I mean, our healthcare system is doing a good job. And that's because we did a good job of bending that curve. What I worry about is if we ever get to the point where we exceed capacity, you're going to see a rapid acceleration of the case fatality rate, the number of deaths. As long as we stay under that and keep each patient at full attention, we do a really good job with the case fatality rate. What we're seeing right at the moment is that deaths lag behind the overall prevalence. And what I mean by that is we've seen a shift from people who were over the age of 60 who had COVID back in March to now in the last week and a half or so, people kind of around the average age around 30 or so much younger people who have a lower death rate. What we get concerned about is that every asymptomatic person or a young person who's healthy that has COVID, for every about 100 of them, we're going to probably see a death. Might not be them who dies, but they're going to give virus to somebody else who's going to get sick and die. And overall, we see about 20% of people who get virus require intensive medical health system resources. And that may not be an ICU stay, but it may be a long hospital stay. It may be downstream physical therapy. It may be a long return to work course. There's a lot of other measures we want to look at besides just ICU and just deaths. Now, having said that, though, the ICU rate is steadily climbing in this area.
Hey, Jason, let's hit a couple quick questions real fast. Somebody asked, why is TGH not doing contact tracing? Are you or not?
Well, so, contact tracing is really a sort of a system thing that needs to be done. It's really not an acute hospital piece of this. Our focus for the most part at a hospital itself is to take care of patients that we see. Now, certainly we do have some public health considerations in that. That's one of the reasons why we started doing testing back in March, and we do quite a high volume of testing because we do want to help with that public health effort. But really the focus in a hospital setting is kind of in the acute clinical encounter. But having said that, I do agree that contact tracing is very important. The governor's talked a little bit about contact tracing. We're still behind though in terms of increased number of people and the technology that should be available to do contact tracing.
What about, somebody mentioned running like on Bayshore? Should they be wearing masks running on Bayshore?
Yeah, good question. As long as you're not going to be next to somebody, right next to them, for a long period of time, there's probably less benefit of wearing a mask in those type of situations. Now, Bayshore gets pretty crowded sometimes. Keep that in mind. If you're going to be in a big throng of people, the benefit may go up. But if you're going on a solo jog or solo run, the benefit's probably pretty low of wearing a mask.
We've had a couple questions about the potential dangers of wearing N95 masks because it would trap something, CO2 or something inside. Any comments on that?
I wear an N95 mask for 12 hours a day sometimes. Hopefully I haven't had any CO2 hypoxia or necrosis or anything in my brain yet, but I think I'm still functioning okay. Having said that though, I think the benefit for the public to wear an N95 mask is probably not there. I don't think it's going to hurt you to wear 95. The only thing I'd say with an N95 is if you're around people with COVID and you're wearing a 95 mask, you actually have to know how to take the mask off as well. So that mask has to be taken off from the back and then disposed of like this. That mask does a really good job of trapping particles. And if an N95 mask is taken off improperly, you basically just spray those particles all over you and you get COVID that way. So that's only if you're going to be around people who have COVID that I worry about that. I probably would not wear it. I don't wear an N95 mask when I'm not in a patient room. I put it that way.
Jason, what about children? Should they be wearing masks, and how young is the child not to wear a mask?
Yeah, good question. When we made recommendations to the emergency policy group, we talked about this a lot too. The overall recommendation is actually not masks, it's face coverings. And because, part of that is understanding that there are going to be both children who are going to have difficulty with masks, and also, there may be some other demographics out there, specific medical conditions or specific people who may have difficult with masks. And so we do try to emphasize that face coverings, at least help. I was telling my 11-year-old boy today, this is already popular in their fashion anyway. They call them buffs, right? The little fishing things that they wear, fishing face coverings. So if you guys have anybody has little boys will know this. So I tell him to wear that. He seems fine wearing a face covering like that. I think that probably works if the kids are, over the age of 6. The ordinance is 2 and over right now in the city. I recognize there's probably some challenges around that. We've seen 6 and over in other places. I think it gets a little bit easier to consider face coverings as we get that old. But do keep in mind that right now, the way the city of Tampa ordinance is written, it's 2 and over.
My kids like wearing their masks. One of them has a Kobe Bryant one, and the other one has a Star Wars one. Hey, another question. You and I were talking earlier about the Swedish model and herd immunity, and can you compare and contrast that to what's going on in Florida now, and when or if will we hit herd immunity? And last part of that, also the externalities of people coming in from other countries and other states. So
yeah, great question. I think one of the things people wonder about is, can we just ride this up and ride this out till we get to herd immunity? We're seeing a lot of young people get the virus right now. They're young. We think they're going to probably do pretty well for the most part. Here's the problem with that. So herd immunity, you can calculate. It's a formula you plug in, depends on some viral pieces. But it turns out that the herd immunity for this particular virus is about 67 to 70%. So let's call it 70%. That means 70% of your population has to have the virus. Well, as our naysayers like to tell us all the time, the prevalence is way lower than 70%, right? Even if we take all the detected cases, consider those the tip of the iceberg, let's say that 10 times that number has not been diagnosed yet. So in other words, I diagnosed 1/10 of the cases are actually out there, and there's 10 times the number of cases. That still puts us at a prevalence of, around 1 to 2%. So that would mean we'd have to get 68 percentage points higher to get to a place of herd immunity. So what's the problem with that? The problem is that even with the prevalence at 10%, where it's risen to diagnosed cases of 10% in the past rolling day average of 7 days or so, the problem is that we've seen a significant increase in hospitalizations. We're still safe. We're still an okay place towards resource utilization, but we are feeling it. The hospitals in this area are feeling it. If we were to get to even a 5, this diagnosed prevalence out there of over 10%, that's always kind of danger numbers thrown out there. 10%, 15%, 20%. If we were to start to reach those numbers of diagnosed cases out there, we would be completely overrun. We had hit that line of where you start to see ICU admissions. And then when you start to see that start to get overrun, that's when that case fatality rate starts to jump. And this has been tested before and has failed. The Sweden model did this. And the Sweden model, the head epidemiologist admitted this is probably not the right decision. But they had the highest case fatality rate of all the Scandinavian countries. And their incidence, their case rates kept on going up way longer than all the other Scandinavian countries. And overall, that's a healthier population than this population. So what that would get us is a lot of death along the way.
Hey, Del, do you have any final question?
Well, I want to ask Jason, first of all, it's been very informative. We can spend more time with you. You haven't mentioned the models in Asia, where they've done a lot of contact tracing and mandatory masks and what have you. Why hasn't there been more of a focus on the successes that have occurred in the Asian countries?
Yeah, I think it's a great question. I think what I've seen for the most part is people are somewhat dismissive of, those areas as maybe either representing different sort of ideological or public health models than what you could get to in the United States, or some concerns about data. And one thing I wanted to say is that, especially when we look at South Korea, I have no concerns about the data that's coming out of South Korea. It's very robust and transparent data. And what they did is pretty amazing. South Korea is a pretty interesting story. South Korea, the same as the US, the same first case, and originally the same curve was happening. South Korea implemented very intense social distancing policies first, relaxed those, but when they relaxed those, they did that with intensive contact tracing and intensive mask wearing policies. Their contact tracing works where basically your cell phone tells you every place you've been where a person had virus, and when you were there and when you were around that person with virus, then mandates that you have a test. I think there's still some discussions that are going on just in the type of democracy we have about whether or not that's going to be accepted here. But I do think people have to understand we have to have that conversation, because if we want to stay out there moving forward to doing things in life and don't want to go back to safer at home, we're going to have some of those concessions to stay safe.
I mean, South Korea has a population about the same as Florida, and their number of deaths is like 15 or 20. Don't hold me on that. So
yeah, their curve is totally flat.
Yeah.
If you want to see an example of a flat curve, that is the example of a flat curve. It's completely flat.
Jason, thank you for going way over time, and thanks everybody for watching. Appreciate everybody who's tuned into this, and please hit the share button so your friends and family can see this. We do this so that we can provide free information to the public, and we want it spread as far as possible. Jason, any final words, thoughts, or suggestions?
No, I would just say, please wear your mask. Even if you don't fully believe the data, whatever it is, it's not going to hurt you. You might help somebody else. Wash your hands. We're going to ride through this thing if we take some of those measures.
All right. Thank you so much. We'll have to have you on again soon. Take care, everybody. Thank you, Del.
Take care, everybody.
Good night.